Ladies and gentlemen, members and guests, new arrival, good morning and welcome to another beautiful day in Port Angeles. But unfortunately for far too many, not only in the nation but in our county, they need drugs to have a beautiful day. Paradise here isn't enough. So many people have become addictive, and again, our numbers here in the county tend to be higher than national numbers. And that's a problem because this scourge not only affects those people that we live with, but it has a high social cost. And one of those social costs is especially in the medical problems associated with it. Clallam County has a very interesting and cost-effective program, especially as it looks at benefits. And today we're going to hear about not only the numbers on drug addiction in our county, but the needle exchange program. So please join me in welcoming Christina Hurst, who is our Clallam County Public Health Program Manager. Christina, welcome.
If I'm not loud enough, just let me know, and I will speak a little bit with the microphone. And I apologize, I'm just getting over strep throat. I still got a little bit of a rasp in my throat, so just give me a little bit of leeway on that. Our program is called the Syringe Service Program, and that has two completely different components. One component is the syringe exchange aspect, where we actually give new and sterile syringes to people that use intravenous drugs. And the other piece is we teach people how to do proper syringe disposal. So I'll give you the example of my son, who is a type 1 diabetic and uses a pump and has CGMs and takes insulin regularly 3 to 4 times a day. He has all kinds of sharps that he has to dispose of. And so we teach people how to put sharps and things that they find, medical supplies, veterinarian supplies, into bottles. You can seal them tightly at the top, put a piece of tape around it, and we have these lovely red labels that we give out at the health department, or you can download them off of our website. Put that label on there, and it can go in the garbage can. It meets our solid waste disposal laws. We want it to say do not recycle. So this is a really important piece that I want people to understand. This is the method that we want people to understand to use if you come across a syringe that is found in public, because it's really important that you know how to pick it up correctly. If you do see a syringe that is found in public, you always pick it up by the top with your hands one at a time. I see people scoop them. I see people pick them up with pliers, with tongs, with garbage grabbers, with all kinds of things. That's more dangerous than using your fingers. You uncap a bottle, you drop it in. Once it is capped and inside that bottle, do not ever open and take that bottle, that syringe out again. This is how you dispose of it. It will not go through the plastic. We recommend the larger 2-liter plastic bottles or the thicker plastic bottles, because as you can see, bottles like this that are more flimsy are not going to be as safe and sterile for you. Anybody that uses this kind of a sharps container, this cannot go in the garbage can. This must be disposed of through a medical facility that incinerates waste based on solid waste medical waste laws. Okay? So this cannot go in the garbage can. So it's much easier to use these methods, and if you ever have any questions on that, I have some great brochures here that explain how to do it. I brought labels, and I also have my business card. Please don't hesitate to ask. I'd be more than happy to come talk to a group of people that might have a reason to need to understand this and teach you how to pick up needles a little bit more effectively. It's actually a very simple process. So the second part of the program is the syringe exchange piece. And this is a very controversial and debatable program, and it has been for 45 years since it's been around. And I will tell you what I know about Clallam County specifically. I'm in my 10th year of operating this program, And we have made huge leaps and bounds, and I will share some of those numbers with you and explain a little bit more detail and give you an opportunity to answer questions. So syringe exchanges have been around for a really long time, and they actually started in the 70s, and they were first recognized as a way to prevent disease prevention in the 80s when the AIDS epidemic hit. So this is a primary route of prevention for HIV and hepatitis C for an intravenous drug user to prevent them from getting any bloodborne transmission. The blood transmission happens from the needle part, not the plastic part of the syringe, the needle on the tip. It's a hollow bore, it holds blood inside of it, and as long as that blood is wet inside of that needle, there's a potential for transmission. So that's why getting them up off the street or picking them up and disposing of them properly is so important. You never want to have somebody use one syringe more than once. Once it's used, it's no longer sterile. But the barrel plastic part of the syringe is not what we're concerned with. We're concerned about the needle tip. That is where the infection happens. So I always tell people, never break the needle tip off. We can't see that. We can see the syringe. So you never want to break that off. You never want to recap a needle that is not your own needle. You just want to drop it in a bottle or a red Sharps container and get rid of it and take care of it. So syringe exchanges have been moving all across the country for 25 or 30 years now, and they are all over the place. The demand for clean needles grew as the AIDS epidemic discovered that there was a bloodborne pathogen, and then several years later we had hepatitis C come along. Our numbers of hepatitis C are much greater than our numbers of HIV, and it is much easier to catch hepatitis C from a syringe than it is HIV. Hepatitis C is more virulent and it lives outside the body for much longer. So hepatitis C is much more infectious than HIV. So people began going into underground syringe exchange programs, taking used syringes, repackaging them and marketing them, which then transfers out to more infectious diseases out into the community with unsterile syringes. So the first legal syringe that was recognized was in 1986 in Oregon, and in Washington State, the first one was in 1988, and that is from the North American Syringe Exchange Network, which is still open and available in Tacoma, Washington. So the Centers for Disease Control recognizes syringe exchange programs, and the World Health Organization recognizes syringe exchange programs as best model practices for working with injection drug users for disease prevention. So that's one of the reasons we do this. So the CDC tells us that HIV cases have been reduced 80% amongst intravenous drug users since syringe exchange programs came into practice. That's a huge reduction in the amount of people getting infected. There's not a lot of good studies out there yet on the reduction of hepatitis C yet. They are still working on that, but we are seeing decreases in hepatitis C as well. So take this in mind. When we're reducing 80% of those those people that use intravenous drugs, to treat one case of HIV costs us a minimum of $250,000. Okay? My program operates at about $70,000 per year, and I serve a whole variety of folks. The cost of hepatitis C treatment can be in excess of $100,000 for one person. So the medical costs for this are phenomenal. And so that's another big reason that we look at this. And when we look at numbers for the Department of Social and Health Services and the program numbers for Clallam County back this up, 85% of our clients are on DSHS Medical, which is Apple Healthcare Medicaid, which all of us pay for. So reducing those costs of medical care is huge in this whole process. This is an idea where syringe exchange programs are all across the country now. They're all over the place. I think on this one there's currently 194 exchanges in 33 states, and this was as of 2014. There may be a few more or less since then. But that's a pretty phenomenal number, and if you look at the map you can see they're primarily in higher geographic locations. So our history began with the syringe exchange program starting in 1990 when we were given a grant from the Washington State Department of Health in response to the HIV epidemic, and we were given a grant to do HIV prevention, which includes HIV testing and counseling as well. And so we started a syringe exchange at that point, and it was started by a Board of Health resolution from our Board of Health in 1990. They felt it was a good idea of the healthcare in the community, and so we have been operating for going into 16 years now. Our funds ran about $70,000 a year, and we were funded by the Washington State Department of Health until 2011, when they no longer funded HIV prevention programs. So at that point, we lost all of our funding. We went down to zero funding. In 2015, the Clallam County Commissioners allocated us $25,000 per year to keep this program afloat, and the total cost is about $70,000 for the whole program. And one of the ways that we do that is that we receive some in-kind donations from DOH. So what that means is the Washington State Department of Health purchases bulk orders of syringes that we have access to, so we're not purchasing the supplies, we're strictly funding our staffing to do these programs. So these are our goals. We want to decrease the transmission of HIV and hepatitis C, hepatitis B as well in our community. And there is HIV and hepatitis C in our community. Our number 2 reportable disease in Clallam County is hepatitis C. That's the number 2 most reports that we see as a public health department in our county. We do have HIV cases, and the folks that have HIV in our community have a case manager that works with them to help them get medical care and medications that they need to maintain and stay healthy. We also want to increase safety by decreasing the risks of needle stick injuries from discarded needles. And I know you hear about people with, finding syringes all over the place. They were there long before 1990, and that was one of the reasons that we started this program as well, was to respond to needles that were being found in public. And I'll get you some real details on that when we go. Yes?
I'm not familiar with the difference between hepatitis B and C. I'm basically with the HIV disease. Can you explain those other two and how people get them?
Yes, it is a bloodborne transmission, the same as HIV is. Hepatitis C is primarily transmitted through blood. Hepatitis B can be sexually transmitted as well. It is transmitted in body fluids, and it is not as virulent as hepatitis B and C. As hepatitis C and HIV. So most people, if they come in contact with it, their immune systems are strong enough to counteract it, and they do not become infected long-term and become chronic. Hepatitis C, 85% of people that come in contact will become chronic.
What is their symptoms?
Jaundice primarily, yellowing in the skin and the eyes. It's a liver disease. Your liver starts going into overload and overworking, so primarily jaundice and flu-like symptoms. So the other big piece of this program is that we want to increase public health interventions and interactions among indirect injection drug users. We want people to come to us, we want to have access to them, we want to talk to them, we want to work with them, we want to get them in services, and number 1, we want to get them in recovery. That's a huge piece for me. We have spent the last 5 years putting interventions in place to move people into routes of recovery, working with treatment facilities, working with social service organizations. I don't want to continue this program either. My goal would be that we don't need it. But stopping it because it's not politically popular versus stopping it because we don't have a need are 2 totally different things. And so let's talk about that a little bit more. This is an idea of what our exchange looks like on a regular basis. This is what the people bring into us. We teach people to put the syringes that they find, that they're using, in plastic disposable bottles. They seal them up with tape and they bring them into us and we incinerate them. So this is an idea of what our trash looks like on a regular basis. We send these off to a disposal company and they are taken care of from there. This is an idea of how many syringes we use in a several years period of time that DOH gives us. So we stop them when they're really inexpensive and we can get them and hold on to them. But this is several years worth of syringes for our program. A syringe exchange. We bring people in and we want to talk to them about intravenous drug use. We want to take their unsterile syringes and give them clean, sterile syringes, but we also want to talk to them about their injection practices. It's 1 injection per syringe per person. Do not share. When people begin using more than 1 syringe for themselves, that's where MRSA comes up, that's how abscesses come up. If people don't hit their veins correctly, they blow out their skin, they blow their veins out, and there's a whole other host of medical costs there. So we want people to be using syringes correctly. And personally, my philosophy is if you don't know how to use it correctly, you shouldn't be using it. And I will talk to people about that. Why are you injecting? Those are the questions that we ask. We want to talk to people about overdose prevention. My very first slide, dead addicts don't recover. These are human beings in our community. A large amount of them work and are in interaction with us every single day. They have drug issues that need to be dealt with. They are members of our community. I don't want to see people die because they have a problem with drugs. So keeping people alive is another part of this program. And when you talk to somebody that has recently overdosed, that's a really incredible aha moment for them. Oh my gosh, I overdosed? And that's a great opportunity to move them in a more positive direction. So that's another big piece of our goal. We work with them about the Good Samaritan Law, which has the RCW written up there at 695315. And basically what this law says is that if somebody is overdosing and you call the police will not arrest you for calling them. Now it does have limitations on it. We want you to get medical care, but if you've got a warrant, we can't guarantee you're not going to get arrested. And if there's not, tons of drugs sitting there, we can't guarantee you're not going to get arrested. But this is a step forward to get people to seek medical care. But it does have limitations on it. So we can talk about that a little more if you'd like to. We vaccinate folks for hepatitis A and B. There is no vaccination for HIV. There is no vaccination for hepatitis C. So let's prevent people from getting hepatitis A and hepatitis B, which would then interfere with their health care, give them comorbidities, and make the health care costs actually increase even more from there. We do HIV and hepatitis C testing. We began referring them because they have a new test out where a person can get tested in 20 minutes and get their test results. It used to be we had to draw blood and they'd come back in 2 weeks and get their test results. We want to keep them right there, give them a test, 20 minutes, and give them their results and talk to them about what are you going to do to stay negative? We're going to vaccinate you. What are you going to do to stay negative? And if they're positive, divert them into medical care. We want to do access to health care. 85% of our folks qualify for Apple Health Care. When the expanded Medicaid went out, we spent a lot of time educating people on signing up for health care so they can get doctors and they can seek medical care. Unfortunately, people that use drugs and have substance abuse problems are pretty marginal when it comes to seeking medical care. They're not a big group of folks that go see doctors on a regular basis anyway. So typically when they do have a problem that is so severe, the cost of that is greatly expanded because they have advanced to a particular stage of the disease before they seek medical care. So again, costs to the community. We give out limited supplies when we have them available. Supplies like cookers, cottons, antibiotic ointments, sterile water. When we get these things from DOH, we give them out. Because
what's a cooker?
A cooker is a little metal cup, kind of like a spoon, where you put the powder on, you put the water in, and then they draw the needle up on the spoon. But you never want to share those. So if 2 people use the same needle, 2 needles are in the same cooker, you have the potential to transmit disease that way. So we want to educate them on that. Never sharing any of the supplies, having your own supplies. We started in May of 2015 with an on-site chemical dependency counselor. So we have a young lady that is there on-site at our facility, working with our folks, trying to move them into recovery and dealing with some of their issues and barriers to get them into treatment programs. This is the same young lady that also works in the county jail with the inmates, which is the same population as the majority of our clients as well. So there's a great crossover there. She has a really good relationship with these folks. We're really trying to streamline this to get people into treatment. We started doing this in about 2011, trying to use volunteers to do this, but we found that having a certified chemical dependency professional on site was key to what we were doing. And in July of 2015, we began giving out naloxone. We received a grant from Clallam Pharmaceutical in July of last year to give out naloxone. That's what these are, and I'm going to show you how these work. And we'll go into that in just a little bit more detail. So this is from our syringe exchanger surveys. Drug of choice. Heroin is going up and up and up and up. It's clearly going up all the way. Meth comes in number 2. We see absolutely no more pharmaceuticals because getting the pharmaceuticals through a prescription is very difficult. And we don't see cocaine anymore, but people are still injecting other things. And something was very interesting to me. One of the recent overdoses that we had, actually 2 of the recent overdoses that we had, the person had been injecting Xanax. So people will inject things other than heroin if they don't have access to the things that they inject. So we're beginning to see a climb up on other things, but we're seeing heroin and meth used to be neck and neck. They're now starting to split and go off in different directions, and heroin is becoming the lead. A lot of people do mix heroin and methamphetamines in the same injection. So this is a chart from 2009 to 2015. The next question goes from 2009 to 2015. How many times did you reuse your last needle? And the majority is 2 to 5 times. And we don't want them to do that, but if they don't have access to the syringes that they need to use one for every single injection, they're going to use their same needles over and over again. And that's where the sharing begins to happen as well, which puts them at a much higher risk for disease transmission. So this is what number of client visits and people exchanged for looks like. The red is for how many people they were exchanging for. The blue is for client visits. So in 2015, the shorter number, 865 client visits in 2015. So we served 865 folks, not one time only. Many of these were multiple times through. And one of the questions that we ask them is, how many people are you here exchanging for? Because not everybody wants to come into an exchange. Not everybody wants to get some of the services. They have a lot of trust issues with organizations that do this kind of work. And so many people will come in and collect syringes and get syringes for 2 to 3 other people. So we have a total number of 2,264 people that are being exchanged for, and those are not non-duplicated numbers. When we look at non-duplicated numbers, we serve about 275 unique individuals every year. So this is when we look at the number of syringes exchanged, and this is a really important piece. In 2014, we gave out 275,000 syringes to our folks that come into the exchange. In 2015, we gave out 221,000. So we're seeing a drop. This is the first time. I was ready to do backflips down the hallway in my office when I saw this number going down. We're serving more people, but we're giving out less syringes. We're still seeing new people coming in. We're giving out less syringes. We're starting to see those changes beginning to happen, and it takes steps to move it forward. The interesting piece on here is, though, that we gave out 221,000 syringes, but we took back in 227,000 syringes. So we take back more syringes than we give out. And people say, how is that possible? These syringes that are being found on the streets, you can buy them legally in any pharmacy. You can get them anywhere. They're not all coming from us, what is being found on the street. And you have folks that do underground exchanges in our own community. We do not condone it, we do not work with them, but we are aware of a group that comes in and passes out syringes, and their logic is get as many out there in the community to prevent disease transmission as possible, but they're not as concerned as taking them back. We are. We're concerned about taking them back. So we're very happy to be seeing more of these syringes. When people find syringes in public, we ask that you bring them to us. We map them. I have a big map on my wall. I keep track of where they were found. I share that information with the city of Port Angeles, and that's how we focus some of these cleanups that you hear about in the newspaper, is based on where these syringes are being found. Any syringes brought into us that did not come from a syringe exchange client are in a totally different category of numbers by itself. So if that's not clear, this number of 227,000 that we took back, those are not related to what people bring us from the public. That number from the public is a totally separate number. I've had many people say to me, well, you're just throwing those in there to make your number look better. No, we keep them separate, we map them, I document them, and we do that so we know where to focus and where to work. So that number is totally, has nothing to do with what's being found on the street. So I just want to make that really clear, because I get that question an awful lot. So when we look at syringe return rates on a national average, nationally across the United States, about 90% of syringes come back to syringe exchange programs nationally. If you get 10, you gotta bring me 10 back to get 10 more, okay? We don't just give somebody what they want. And we ask them questions. How many times a day are you injecting? Well, if you're injecting 3 times a day, you can come in once a week. I only need to give you 25 syringes to get you through until next week. You bring me back those syringes and we'll get you more. So we talk to them and we really try and hone it down and work with them on these other aspects. And for me, any route into treatment is the greatest success that we can have, and we're seeing those. We're seeing people coming back and saying, thank you for helping me. That is why I do this program. So we started using naloxone, and what naloxone is, it's an opioid overdose candidate that if a person is overdosing on opioids, you can give the person an injection of naloxone, and it blocks the receptor cells in their brain to prevent the overdose from shutting down the respiratory system. That's what an overdose does. You stop breathing, you die. So we want to give that person an injection to prevent them from not breathing and dying. You have to give it to the person fairly quickly, and it gives them about 45 minutes to 90 minutes to get to medical care. Now, anybody that comes into our exchange that gets a pack of naloxone from them signs a contract with us that says, if I use this and overdose, I will seek medical care. And they're doing that. They will not get refills from us if we don't see that they're following the agreements that they have made with us. We don't just hand it out. We encourage them to teach their family members how to use it and the other people that they inject with how to use it to save each other's lives. And we are seeing that happen. It is a little box that looks like this. We got this from a grant from Clallam Pharmaceutical. This is what naloxone looks like. Naloxone can be injected and it can be given nasally. We're choosing to use this one because this was a free product donation that we got of the latest brand that is just coming out on the market. So we give people 2 of the containers. These are 2 actual doses of naloxone. If the first dose does not work in about 2 minutes, you need to give somebody the second dose because they've progressed past that timeline, and usually the second dose will help them. So we give them 2 of them. And we also give them a trainer. And what this trainer is a dummy sample of what the pharmaceutical looks like. It is non-addictive, it is not harmful. If a person that didn't have opioids in their system were injected with this, nothing would happen because you have no opioids in your system. It's not addictive, and it's not harmful, and it gives the person the opportunity to get to medical care. That's the goal, get them to medical care, and then we have those interventions that come in. The hospital works with us, gets their counselors in there, we get people to treatment, we work with them on what's going on. So we teach them how to use these, we show them a video, we ask them to sign a contract, and we spend a lot of time educating them on how to use these. And this is the coolest little thing, I just have to always show everybody how these work. So you teach somebody how to use this, and hopefully you can hear it. You can pull it out.
This trainer contains no needle or drug.
So there's no needle or drug, that's what the machine told us.
If you are ready to use, pull off red safety guard.
If you're ready to give the injection, you pull off the red safety, you take it off, pretend I'm using my thigh.
Press 5, 4, 3, 2, 1. Injection complete.
That's how simple it is to give this injection. And so we teach people how to use these to save their family members' lives and other people's lives. And that's why we chose this brand. Not only were they free, and I give a lot of plugs to Kaleo, we have gotten 2 donations from them for this product. But it is such a simple thing to use. But the folks that come into the exchange need to understand, you don't give naloxone and you're done, because that doesn't mean you're out of an overdose. You need to be evaluated for the overdose status. So we got our grant, and then we got a second grant in November, and our grant runs out at the end of April, and we will be purchasing naloxone from there on out. We haven't decided how we're going to do that yet. But that is giving you an opportunity to see what the actual FZO looks like. So we have a lot of challenges. Funding is huge. When we had funding from the Washington State Department of Health, we were doing awesome. We had all the supplies we needed, we had everything we needed. Naloxone wasn't even very prevalent at that point. We have issues of access to medical care. Getting people to sign up for insurance and getting them to doctors is very difficult. That's not high on their priority list. So for somebody to come and talk to us about an abscess that they have is huge, because they may not go to the emergency room. We're going to get them to the emergency room if they come in, but for them to have that relationship built with us to come in is huge. And that's where making these step forwards helps us get these people moved into paths. We work with them, we build a rapport, we build a trust. It's very important. We have a shortage of drug treatment in our community. We need a lot more drug treatment. When somebody comes in and says, I need treatment, they should have a bed waiting for them at that moment. That's how we're going to make a dent in this epidemic, in my humble opinion. We do not have enough drug treatment. We also need medication-assisted treatment, meaning we need to begin using drugs like Suboxone to help people taper down and withdraw off of heroin. Suboxone is looking to have better results than methadone, and people don't need to be on it as long. Our unauthorized syringe exchange programs that I talked about earlier, that becomes a real problem for us, because people look at us as, oh, you're not doing anything, and your syringes are all over the streets, and really we're doing everything we can, and we're out there trying to clean up with everybody else as much as possible. So those create a problem. And then one of our big issues is public perception. This is always going to be a debatable program. People are not going to like it. People tell me I'm enabling addicts. You know, they're going to get needles and they're going to use them regardless of if they get them from me or if they get them from somebody else. And so people will inject. I spent many, many years working in the prison system with intravenous drug addicts. And to watch those guys take big pins and make injection equipment out of a big pin and a stapler or a paper clip was appalling to me. They are going to find a way to get it in their veins. Only when they do it with a stapler or a paper clip, the damage to the tissue around their arm is 10 times worse, which raises the amount of infection, which then creates a bigger problem. So we're always going to have a debate on this program. I gotta say, I'm extremely thrilled to be doing this kind of program. When I have people that come into my office and say, thank you, I get tears in my eyes. I'm a person in long-term recovery. So I understand the drug issue. I see it, I understand the brain-ism around it, and that's another motivating factor for me to work with these folks. I went from being a high school dropout to being a public health program manager, and if I can do it, a lot of other people can do it too, and there were a lot of people there that supported me and helped me when I didn't deserve a break, and I'm very grateful for them for being there. If you have questions, I'd be happy to answer them.
Great, thank you, appreciate that. I'm going to start the questions, but first I want to comment. I worked 8 years in the Department of Corrections, with Clallam Bay as well as down at Olympic Corrections Center. And the issues around Hep C, drug usage and different things you've got are just off the charts. In terms, we figured at one point 70% of our inmate population had something which we did not want to see get transmitted. And that's a reality when you're working with it every day. It's just something that kind of get kind of casual and kind of get used to. So that's one comment I would make. The second one is she referenced MRSA a little bit ago, and I don't know whether many folks in the room have familiarity with what MRSA is or what it looks like. I will tell you, I've seen several cases of that through the correction facilities I work in. It is not pleasant to go through, and if we can do something to reduce that in the community, that's a worthwhile objective. We had a question from Edna.
From Edna. The only thing I know about needles is a diabetic dog that I gave him shots twice a day. I know what those needles cost me. What are you paying for? What, you know, what is, Patch was awful, but he was a little dog. What are they spending on needles?
The syringes that we purchase, when we purchase them, we've been getting them from in-kind donations from Department of Health for many years, but when you buy them in bulk, we're able to get them for about 7 cents per a syringe.
Wow.
They come in packs of 10, and you can buy them at a pharmacy for about $3 to $5, depending on what pharmacy, in a package of 10. So they're fairly cheap and easy to get. They're designed to be tossed away after one use. That's why they're made out of the plastic.
My dog was more expensive.
I'm going to ask for a comment from Terry in terms of the drug issues and drug usage you've seen in your career, an increase of that, I'm sure.
Well, the only reason I'm here today is to support Christina. You can make a business case for needle exchange programs quite easily. If you bring Eric Lewis out here from the hospital, you've probably done that in the past. Prior to the Affordable Care Act, the hospital, Eric had said they had over $500,000 a month in uncompensated medical care going through the emergency room, $6 million a year. Maybe higher than that now, it might be lower. But the work that Christine's doing is saving us a lot of money on the other end of the system. We would be spending hundreds of thousands of dollars providing medical care to these people. So, you know, I kind of look at it if we all decided to drink beer and we were going to share a glass, we probably wouldn't want to do that because some of us would get sick. But it probably wouldn't keep us from drinking beer if we're the right kind of person. I mean, I don't have any problem with giving IV users clean needles. I think it just makes good sense, and I think you see that hundreds of communities around the country are doing the same thing.
Well, the cost, the human cost is just off the charts.
Right.
You can't quantify that amount. But looking at the fiscal numbers, and you think what we see locally in one rural community, I mean, this issue's out in Forks as well. I mean, I know a lot of the areas that we've done hiking trails and areas we've walked in, well, I personally have found, as my daughter, needles in places you would not believe there would be needles. She's reluctant to take and will not take her dogs into some of these areas because of her concerns about her animals getting stuck by some of these needles you lay around. So you think about the fiscal issues associated with this in a small rural county in Washington State. Think what King County's going through, Pierce County, and then think about it nationwide. I mean, I struggle, and as a former Department of Corrections official, I struggle with the illegal components of these activities, but the fiscal numbers are just, they dwarf the concerns that we've got nationwide. This is an issue of immense significance. Other questions? Yes, sir. George?
Question for Terry and Christina. You made reference to the jail population. In terms of new incarcerated individuals, what percent of them have drug issues like you described?
Well, I can't tell you from Clallam County, you may have a better understanding, but I spent 10 years in the correctional system in Phoenix, Arizona, and it was close to 95%.
Terry, do you have any idea how many Bill Benedict takes in?
It's very rare that we arrest anyone who doesn't have a substance abuse problem. I always say that all our heroin addicts are criminals, but all our criminals are drug addicts.
Wow. That's consistent with the numbers the Department of Corrections sees as well. Other questions, comments? Yes, sir.
I own a number of properties through town. I've had to harass a couple of drug operations off of them, which basically Mr. Gallagher, they have their method of doing things, I have mine. And where I see the naloxone program, I see that as just a commodity to be used. If somebody doesn't got any drugs, this is going to be a commodity to the drug dealers. And so only emergency personnel should be distributed with those. It seems ridiculous. Me and Christina we're polar opposites. I don't agree with the needle exchange program, but I recognize it as a necessary evil, the lesser. And so that I agree with. The naloxone program, I don't want to put a penny into it. And with all the burglaries I've done on my properties and dealing with these drug dealers, when we're cleaning up piles of needles on the ground, break them into a pile, build a fire on top of them, thermally destroy them. And so I do know of a couple of people, one a good friend of mine, another one a police officer over at the Arlington Police Department, who through picking up needles have contracted the hepatitis. And it seems so simple to pick these needles up and whatnot, but it should only be done by trained professionals. It really should only be done by trained professionals. A lot of people think they're being careful, but a lot of them, maybe they're not physically capable, they might stumble, it takes trained professionals to really handle that stuff. And when I look at the situation, and I've been a advocate of suicide prevention on the 8th Street bridges, which I see this drug thing as being a major product of. I also see it as negligence on the part of the city of Port Angeles. And you know what? When I look at it, I see a situation where we're teaching these people that it's safe to do drugs. When I was brought up, if you smoke pot, you would go crazy. You know what, it's a different day. Now you can do heroin and stuff like that all you want. We're going to give you needles, we're going to give you an overdose kit. We're going to support the drug dealers that are doing this because it is a commodity. And so, we're polar opposites. We've been at the PA-CAN meetings and whatnot, but, there needs to be a balance found.
Well, there's no doubt this issue will be debated long into the future, and there'll be both sides of this thing, but I'll tell you, this is not going to go away. Yes, ma'am.
Hi, I just a quick question. Does the program not use the single-use retractable needles because of the expense, or?
Yes. Yes.
Question here?
I want to commend you on your presentation. I thought it was very good, and I think you probably saved a good number of lives.
Thank you.
I would like to hear from our politicians. I'd like to see our politicians.
You're looking at me when you're saying
No,
that.
I'm looking at you because it's the only guy I can direct the question to. But I'd like to see our politicians come here and explain to us what they're doing about cutting down the source of the supply. I mean, if you don't have a supply, you're going to cut down on the use. Simple as that. And this is, I remember hearing about heroin as a kid many, many years. That's been many years ago now, but there wasn't a whole lot around because there was a big intervention process going on. I'm not sure what's going on now. I'd like some politician to come here.
Well, Andrew's
Explain
around,
to
there's
us.
another program request that we have. Where you went.
He left already.
I agree, I think it'd be a good program.
Well,
Dick?
there.
Is your program successful, and how do you portray success?
For me, I portray success as seeing our numbers beginning to climb for the first time in many years, but I also gauge that by the amount of people that I see coming in and talking to me and saying thank you. How many people that have said, you know, my favorite story, we were in the middle of our measles epidemic last year in February, and I had a waiting room full of people in our office waiting to get vaccinated for measles. And I had a gentleman come in and says, I want to talk to the manager. That's not a good thing when people come in and say that, when you have a good lobby full of people. And my staff was standing behind me, and this man came out and he said, I just want to shake your hand for running this program. Your nurses worked with me, got me into treatment. I've been clean 9 months now, and I just wanted you to know I wouldn't have been able to do it. And those are not unusual types of things that we see. People come back and talk. We document people using an anonymous number system. So we don't keep track of names, but we can go through and see how numbers are sliding off. The problem is the numbers are also increasing with new people. So how do we stop that revolving door? We're seeing those numbers of people getting lower, but new people coming in. So let's see them get lower and let's stop the new people coming in. That's my goal.
We are at our limits for time unless there's a motion to extend the meeting. I'm going to conclude the meeting. If there's not a motion, I want to encourage folks to show up at the port. And we have one of our members being sworn in today, a very important event. I want you to join me, please, in thanking our First Lady.
Can I say one more thing?
Yes.
Very quickly. I left my business cards up here, my telephone number, my email address. If someone tells you this is how you pick up a syringe, please call me and ask me. I would be happy to give you information. When somebody says, oh, I saw it on Facebook, that's like telling me you're reading the National Enquirer for good information. It is not a good place to get information. Please call me, speak to a nurse, speak to my staff. We are all highly trained in how to do this, and I even come out and help people if you have real problems. I've gone out and helped people. So please go to the source and do not rely on my friend told me it's done like this.
Well, thank you again. If there is no other business,
I just want to quickly remind everybody, Port Angeles Chamber is the largest organization on the Olympic Peninsula, 5:30.